So I'm going to talk to you about the tools for investment case, really just one tool, and then Jeremy will talk about another tool. There are mainly one Excel-based NCD tool that neither Jeremy or I are really familiar with, and so we're not really going to talk about that today. Following questions or some additional time, maybe James can answer something more about that. But so I'll get right into it. So before looking at the tool in detail, I thought it was nice, since most of us are economists and like to have numbers in front of us. I always like to put things in context with the numbers as to why we sort of go back to talking about this. NCDs have been calculated to contribute to 4% GDP loss for the globe each year, and are about 60% of the disease burden of the world, but are underfunded. There is no global fund for NCDs. Only less than 1.5% of all sort of donor funds go to NCDs. And within the epidemiology, the estimate is that over 16 million people die preventable or premature deaths due to NCDs, and that these are not just, as you sort of, as tends to be assumed to be in upper income countries, but in lower middle income countries. So the idea that NCDs are something for the wealthier countries isn't really true, or that the lower income countries don't really have to worry about NCDs isn't really true anymore. So to put this within what we do at the headquarters global level of the WHO, this sits within work called priority setting and cost effectiveness analysis, which is under our something called WHO Choice, which stands for WHO's choosing interventions that are cost effective, which comes to choice. And the idea there is that we analyze different interventions, different things that you can do within health, and compare them in terms of how much they cost and how much you get out of it. And we have looked at over 400 different interventions, over 20 diseases or risk factors. And an additional sort of thing that we're very proud of is that we're not just comparing one versus the others in an empty space, but we're actually looking at them as packages. So we know specifically within NCDs there's a lot of things that don't really make sense to think about by themselves. We have been able to sort of package different things together and see how cost effective they are or not. We do this on sort of two levels. One is on global work, and another level is at the country work. And so the WHO Choice idea is to give tools to be able to look at country level cost effectiveness, to help people at national levels making decisions about what sort of interventions are the best to be used in that country at that time. Through the global work, we also have come up with data. So we have a lot of configured at the regional level cost and cost effectiveness data. So the positive side, even though this comes out to be developed by what donors have wanted to do, or the global community has wanted, it means that now practically everyone has data at a regional level that's applicable to your specific country, your specific context. And the really nice thing is that both the work that we do at the global level, but also country level work that you would do, sits within our OneHealth tool. While this is only one part of it, as what was presented before, the economic burden and impact sits outside the OneHealth tool and will be part of something called the EPIC tool, which is something still in development that Jeremy will talk about later. So if we think about where the investment case sits in sort of a wider process, it is really sort of within priority setting, within trying to figure out what should be the priority within a country. And so we think of this as the analysis that we come up is just part of the larger evidence base, and that we really try to make it, through our quantitative analysis, be as unbiased as you can possibly be, and for it to be rigorous so that you can present it as a good piece of evidence, something that is convincing to decision makers. And these are different ways you can sort of use this, and within the investment case we look at cost effectiveness to a certain extent, but mainly costing and then returns on investment. So for the audience here, one of the things that has come out of this work has been the Appendix 3 of the Global Action Plan for NCDs, which in essence came up with, doing analysis, 88 interventions that are really cost effective and 16 that are very cost effective, really cost effective, that all member states should really consider using. So the idea here is the countries you may end up working in or are working in probably have a list of things that they're already doing. And most of the time it's only going to be a discussion about what new things a country should be doing, but the sort of way to think about it is maybe the way things are done now are perhaps not the most cost effective or not the most efficient, and that this, as a result of our work, are a list of interventions that is a good starting point to take. So James walked us through a little bit about the steps in doing an investment case, starting from the burden and then moving onwards toward the right. And the OHT really looks at, and alongside the CIA, the Concurrent Institutional Context Assessment, but the OHT looks at these two areas specifically. How much is it going to cost? And what are the gains that I can expect to get once I make these investments? The other tools will be the ones that really do the other circles. But since I come from a more health system-wide expertise in using the OHT, that's why I really feel like I can present to you. I mean, we could have gone into some of the others, but then it would have really been me reading someone else's slides. So best leave it like that. So the OHT is a tool created by a wide group of actors in 2012 and has been used in over 30 countries so far. And its base use scenario, as we call it, is really to help countries come up with their national strategic health plans. So it's really a wide scoped tool. It looks mainly at plans going forward, so something looking at the next 3 to 10 to even 15 years. And it really tries to be integrated, to look at ways that different sectors interact with each other. In terms of its application, even if all of these groups or these agencies participated in creating it, its actual implementation happens by many different actors and not specifically by the WHO. We tend to really spend more of the time developing the tool and fixing the tool and trying to convince others to use it than actually using it ourselves. So what can the OneHealth tool do? It can do many things. So I mentioned the strategic health plan above, but there are other things that you could possibly do with the tool. You can try to think of what your basic health package should be and thinking about what the most cost-effective intervention should be. You can think about how you're going to reorganize your health system, and the results from the tool can help to that. You can really focus it on your budget and what you want to do within budget. And then you can do things which we are here for, which is more the investment case and work that is linked with that, but which also in the end really goes about the red being the sort of the final goal, which is how do we optimize the health system and the resources that we have and the outputs that we can get out of it. So these are the countries that we know have applied the OneHealth tool. You sort of see a lot of green in particularly in sub-Saharan Africa. That's where we have a lot of interest so far in using it. But besides sort of where in the world it's split, there's a big split between how it's been used. And you see the blue bar most of the time. It has been used to do these national sector-wide plans, and more recently have been focusing on things like this, sort of an NCD plan or an NCD investment case. But the tool is set up so that you don't necessarily have to consider the entirety of the health plan, of the health sector in doing a plan, but you can see how investments in NCDs affect the rest of the health system, or how you need to maybe also consider about investing in other parts of the health system to make changes in NCD investments really work. And I'll get to that a bit later. Yeah, so I mentioned this before. So the really interesting thing about the integrated aspect of the tool is that you have dynamic models that link to each other. I like to think of the thing I like best was if we are focusing perhaps on family planning interventions in 1 year, that means the next year you're going to have fewer births, and that means the next year you're going to have fewer vaccines. And so the tool takes into account how all of these things link to each other. So if you have some family planning, but then you're really focusing on NCDs, you may end up figuring out that something that targets, not necessarily family planning, but that targets children might be something that has a bigger impact than something that's much more obvious, that's treatment or prevention for adults. So it really works on population growth, on mortality, and on incidence, and how all these three things actually link together. So if you have changes in incidence, you may also then have changes in mortality. So for us, what we're really interested in, on one side to begin with, is what the costs are. And this flow chart sort of looks at that. What we really want to get to is that box on top. And to get to the box on top, it's split into really three things. When you look at a service or an intervention, who needs or who is going to get it, which is the population in need, how much of that population is currently receiving a service and how much you want to get to, so that's the scaling up terminology, and then how much it costs to do that. And there it's split between how much each sort of input costs and then how much of these things you need to have. And all of this is within the tool, and all of this already has default data, but all of this is also changeable. So if you know that there are some drug prices that have changed or that are updated in your specific context, you can go into the tool and change that, and we'll go through that part as well. So the OHT can do many things and related to us. Maybe the three on the right I've been sort of talking about, but the really interesting thing within sort of this investment case scenarios that I really like is, the investment case is scenarios, making up possible different strategies that you could do in a country, that were also mentioned by James, in how, depending on how ambitious you want to be or what kind of targets you want to be, or if the first time you run through it you realize that you've overshot completely and you don't have that many resources, or that it's going to be too expensive, and you can then compare between different possibilities. And that means you can then go back and readjust what you're going to plan, and then have it be a sort of an iterative process. And the linked aspect that is also a really positive side of the tool, which one of the reasons we really like it, is that it links between the things that are specific, in this case specific to NCDs, and those things that are shared. So that we look at, the tool allows you to look at not just what you need to invest in specifically for NCD interventions, but the things that the entire health system needs to have in place, like facilities or health workers. The tool is really extensive. It covers all of the things you see here in these three boxes, and you can look, or you can do an analysis from any one of the things within these. So you can look at it by program. You can think about making a child health program if you wanted to, if you're an NCD program. You can also think about it as if you wanted to do your own district hospitals program, you can look at it only from that level. Or if you wanted to focus on a sort of a sector of the health system, if you were focusing on wanting to think about what the challenges for logistics and supply chain was going to be, you can also just sort of focus on that. And then it all links. So if you make changes in logistics, then you can see what's going to happen in terms of outcomes in NCDs or in malaria, if that was the case in your country, or you can end up seeing what that means for the different district level results. So this is a nice visualization. You have the different levels of delivery on one direction and the different programs on the other direction, and the shared resources that sit underneath. And so when you sort of fill in the information on what is in place now and where you want it to get to, you then end up with what the expected outcomes will be after you increase coverage of whatever interventions you have. And then you can take that result and compare it to how much it costs and how much you expect to have to spend. Usually you're going to want to do things very ambitiously and then realize you don't have enough to do that, and then you have to readjust. So there's a separate financial space module within the tool that allows you to do this quite quickly. So the second aspect, beside the cost that we were interested in, is exactly this, the health impact, the outcome side. And that happens through 4 ways. And it comes from each intervention having a specific effect and having an effect in 4 ways. One could be what the incidence is. If you invest in preventative activities, then you're going to have a lower incidence of, let's say, hypertension. If you invest in a treatment, then you're going to have lower mortality. If you invest in a kind of treatment that prevents moving from a state of hypertension to a much more serious health state, then you're going to have higher levels of remission. And then similarly, if you have certain interventions that focus on quality of life, then you're going to see prevalence ratios perhaps drop. So the tool is split into 3 ways, which are linked exactly to the 3 columns in the previous diagrams. One, which is the service, if you're looking at it specifically between programs. One, if you're looking at it across the systems, being sort of infrastructure or the different pillars of the health system. And then another one, which is all about the results, the impacts, the outcomes. And if that's not really fast and not too fast for you, then I'll go into a bit more detail on how the tool does that.
Does anyone want to ask any questions at this stage? Any clarifications? Okay.
Okay. So there are a couple ways you can calculate costs, and we do it in the tool at the sort of the ingredients based, sort of bottom up way. So we try to calculate exactly how much each person or each intervention at its final point will be based on the price of all its components, of all its ingredients, times the number of times it has to happen. The number of quantities comes from numbers 1 to 4. So I'll go through this in the tool itself, and it's not so intuitive to figure out. So the first thing you have to identify is what is the population. If you take an example to make it a bit easier, cervical cancer, the population is going to be women. Then the population in need is not going to be all women. You would probably want to focus on women of a certain age. So the target population would be women, but then the population in need might be women over 35 or over 40 or whatever as a medical specialist would recommend you to do. And then the third one is, how are you going to do that specific intervention? Is it going to be only at sort of complex hospitals, or can you start thinking about delivering it in a more primary healthcare setting? And then the last one is, of course, what the percentage of that last population need is going to actually receive it. That's coverage. And for us to use the tool, the coverage is the most important thing, and that's what we are going to, besides maybe the delivery channel, going to try to change, going to move up when we're talking about really scaling up and seeing what the impacts of investing in NCDs would be. And then the other aspect, of course, is what the prices are. And that's the last bit, the inputs being what the medicines are or what the kind of health workers or time that you require for that. There's additional costs that you have to take into besides the interventions themselves, and that is everything that goes on sort of behind the scenes within a program. So if you have an NCD, you want to invest in NCDs, you're going to have to also have a team either at a central level or at a sub-central level working on making sure this works. So you're going to have to have some more workers being in the Ministry of Health or wherever. You're going to have to train people. You're going to need all this stuff, everything that's on the list here. And the tool has ways to add this information, and it can also go into quite a bit of detail for that. The health system sides are these 6, which I'll show you as well. But maybe the more interesting thing that you like is what you can get out in terms of the results. The tool is set up with 2 blocks, summary outputs and summary standard outputs. that give you over 100 different menus of different kind of results and outputs that you can get, that are all standardized, that are all sort of preset, that meaning it's easier to come up with a set of results that you don't really understand than it is to make one. For us, they're maybe used to, well, now Excel is really easy to come up with outcomes and results, but for those that tended to be working with numbers, it's quite difficult to come up with a nice looking outcomes or results graph, and this is the opposite. If you're also linking to where the money is going to come from, there's also, as I mentioned, this financial space module. You can set up already where you think the money is going to come from, or where it is already coming from. If you're going to think about, if you're going to invest, where you're going to need to ask new funds to sort of come from. And there's some sort of standard funding sources in the tool there too. So what do some results look like? So this is an example from one of the cases, this is a national health plan case. So there was an ambitious plan to increase investment on HIV/AIDS, and this is what the tool will give you. So in 2010, this country came up with this plan, and it showed that over time you're going to have a huge new number of mainly malaria and HIV visits by patients. So you could really see directly what changing the targets and the coverage levels on those kind of interventions would lead. But that's just the volume. Another side that you come out with, and that is sort of a common thing that happens, is you maybe are a bit too ambitious. So this was a case of a country that wanted to increase investments in child health and NCDs. And this is a result showing the number of health workers you require, full-time equivalents. So we put together on the left side of the bars the time you need for the different health programs, and then on the right the number of health workers you already have. And you can see that there's a gap, so that even from the start you are already trying to plan to be a bit more ambitious than you can be. So that looking at this makes you think, oh well, maybe I also need to put more investment simply on the building block side, on the health worker side. But if you were only looking at this within a program, if you weren't looking at this through the tool and it's across the system-wide circumstance, both for child health or for NCDs, if you compared just how much health workers you needed to deliver those interventions versus how many there are, it wouldn't look like there was a gap. Because the turquoise bar, the blue bar on the right, is bigger than any of the individual bars on the left in any given year. So you would get a sort of false impression that your plans would still be quite feasible if you didn't put all of the different sectors together, or programs together. This is similar to the slide I had before, but the thing I like the most is the one at the bottom left, that you can compare what you're doing as sort of coming up with an NCD investment case with someone that's doing in the same country one for maternal or child health. Because if you do them within the same projection, within the same tool, you'll be able to see the things that you're putting as a requirements on the system together, and then also what the outcomes of your plans are together. So here's another number example looking at scenarios. As we said, the nice thing of the tool is that you can set different levels of ambition. This is a real country case from Burkina Faso, and it was sort of scaling up mainly things to where they were now, to slightly ambitious, quite ambitious, and really ambitious. And you can see that the tool gives you this really sort of snapshot idea. This is how much it's going to cost. You can see it costs a lot more to be more ambitious. You can see that the health workers you have are only really going to cover you in the first scenario, but that the effect you're going to have is substantial if you were to be able to get the middle or the last scenario, because the mortality rate drops. The number of interventions that are in the tool are constantly being updated, and after the appendix publication, all of the interventions that were there are now also in the tool. Now, within the NCDs section, we have these areas that we cover. We have 4 diseases, cardiovascular diseases, diabetes, cancer, and chronic respiratory diseases, and 4 risk factors, which are the things that impact the others. And except for the chronic respiratory diseases, we have a link between all of these. So it's it's a bit different. NCDs is so far the only one that has this sort of dynamic stepwise model within the tool, that you're not just doing something that immediately causes a reduction in disease, but a reduction in sort of the state of health. And I could go into a bit more detail, maybe even James could or Jeremy could, but it's worth talking about that this sort of transition between health states is how the model or how the tool really shows or calculates what an NCD type of intervention is going to do. That it works on many different ways. It can work on if someone is in a state of sort of really bad, sort of a stroke state, keeping them alive, or preventing them from moving from a state of risk into having a stroke, or preventing a person from moving from a state of good health into a risky state. The advantage or the benefit is that we really try to have regionally calibrated or even country-specific calibrated models so that they're actually reflective and able to be used in not just sort of at a global sense, but in specific countries. This is what the tool looks like for the NCD impact modules. Those are the specific risk factors and diseases that are there. And the idea is to constantly keep adding and making these more extensive. There's quite a bit on mental health and mental health disorders. And the thing that we really like is the results that come out are always compared to what if you didn't do anything. Even if you don't even have to have multiple scenarios, everything you do is going to be compared to what if you didn't do anything. And that was really what's worthwhile to put when you have the investment case scenario. Because it shows, because otherwise it would be kind of difficult to figure out. Based on what is happening now, you would have a number of people that would be sick, or that would be not getting sick, or would be getting better, or would be getting worse. So here it gives you what would happen if you didn't do anything, and what would happen if you're going to make more investments. And that gives you this third row in the table that, in this case, is additional healthy life years from people in cardiovascular disease interventions. And this is from a specific country as well. Scaling up several interventions meant that line was a bit less, the graph could be a bit better, but it's not going up and almost really flattening out. Or for mortality instead of the one before, which is incidence. So the tool produces graphs and tables for all of the things we talked about before: mortality, for instance, for the different states. Another real country example, when we talk about the numbers, was one of the first ones that was done, Barbados. It gives you an outcome as to what the investments are. Sometimes we really want to know just what the total numbers are, but you can also see it broken down as to, are we going to really be making an investment in drugs, or as we were talking about before, is it really going to be focusing on maybe policies? And things aren't maybe that expensive, but they can really make a difference. And sort of each country can decide, but the tool will allow you to see exactly what the money is going to go to. So a lot of things to think about. Maybe it come out a bit better when I walk through the tool a bit later, but we have tried to accept the fact that the tool is quite complex and that there are many ways you can try to get additional help or feedback from it. There is help within the tool itself, where you write to the developers and they write back. There's a extensive manual, and there is sort of pop-up help screens, as in sort of most Windows-based programs. Beyond that, Karen and I have been working on a e-learning course on the tool, which is almost done. Would have been practically launched already if it wasn't for a few small things that we still needed to fix. And it has 5 different components, and one of them is program-specific or sub-national applications, which this case would be. And this is something that is trying to move away from having to be sitting in a room with a specialist behind your computer to learn. This is something so that you can learn how to use it yourself. And the idea is that there are exercises and tests so that by the end of this, you could do a test yourself, send it back to us, and if you pass a certain level, you would sort of be pre-authorized or pre-accredited to do this tool, apply this tool in a country. So what do we really want to get out of all this? We want to have a calculation that says how much investment do we need? Then what is the economic impact going to be, which is the graph on top? Then putting those together, what is the return on investment going to be? To then have that as the real message that we can then take to decision makers and say, look, if we do this, it's not just good because it means better health, it's good because we're going to have this of an impact directly on the economy. And we suggest that these kind of interventions are what we do, and that we hopefully actually have direct results and actions in countries. So a few quick lessons from the applications in the countries. It's really worth having, besides the sort of the external team, having someone as an in-country consultant that can just focus on gathering data. The commentary that we get back the most is that the OneHealth tool needs a lot of data. With any sort of model, the more data you get and the better data you get, the better the results you get. You have a lot of default data there, but the more you improve it, the better the results are. So if you can have someone that works on just getting data for like 2 weeks, it makes the results a lot better. Coverage, as I mentioned before, is the most important thing. It's very tempting to sort of say, no, we don't want 80, we want 90, we want 90% coverage. That can be really the most important thing that leads to a huge chain of events down the line. More what the costs are, what the impacts are, how things link together. And the result, the sort of lessons are, the first idea tends to always be a bit too ambitious. And so you should maybe expect this is something that will likely happen, and take into account that the scenarios built into the idea that you can make scenarios in the tool is something that can be proposed from the start to sort of say, 90 is great, but why don't we also do 80 and then see what happens? And the final thing is the OneHealth tool really focuses, as its name, to be something for across the health sector. And we know that in NCDs or in other things, it isn't always about things you need to invest in within the health sector. So to really make the investment case comprehensive, it's important to try to think of what these non-health sector investments would be, and we have tried to explicitly made it so that we don't put many of these in the tool because we really don't know what they should be, what the literature behind it says the impacts would be, what the costing says would be. But it's not a justification to just leave them out, to sort of at least keep them in, especially in things like the effects on the labor side and the indirect economy. Final thing, the biggest constraint always is what the capacity within the country is, and what the sort of the support one can expect to be within the country. And that's why we sort of have seen specifically within NCD investment cases that international assistance is really, really helpful. It's sort of why we're here, to a sort of sense. And that the biggest reason why we're always doing this is that it serves as a foot in the door with Ministry of Finance. Health and finance don't usually talk in the same language. So talking about health in terms of return on investment is a way to get started. And then once you have sort of started convincing them with economic arguments, then it's a good way to sort of talk about what people in public health, or what the Ministry of Health is going to want to say is important to bring up that. One thing to keep in mind, maybe especially keep in mind in this region, is that it isn't only talking about what's going to be new and what you're going to be adding to the system that maybe is the best to focus on, but what things are already there and how you can possibly adjust how interventions are already being done. Because the tool itself doesn't sort of give you a pop-up window when things are being done in a level that isn't the most efficient and the most appropriate. And for that, we've started doing a bit of work on identifying leading causes of inefficiency and efficiency analysis. And I think that's maybe the best way that these sort of issues can be taken. But if since the tool lets you say change interventions being given at a complex facility to one that's more primary, you can see what the impact would be by not just necessarily raising the coverage levels or adding new interventions, but simply changing the service delivery level. And that sort of maybe simply increasing efficiency is the way to really get to where we want to go. We really want to reach the NCD goals or reach UHC in general. So I will switch over to Jeremy for the EPIC tool before I'll do a live walkthrough of the OHT itself, and then tomorrow we'll pass an exercise to use on your own computers with projection that sort of runs through really quickly or basically how the tool works and sort of the steps that you need to do if you were to do an investment case. So.
Okay. I have a question about costing.
Yeah.
Right? Because we are making cost of illness studies here, we have a problem that when we try to calculate the costs due to the increasing number of hospital stay or visits to doctors, our policymakers tell us that our system is very strictly managed. Yeah? We have a fixed budget for healthcare system. So if the system increases the number of visits, the only result is that one visit is just cheaper. Yeah? So you can calculate anything, but we will give you fixed sum of money, and it won't be changed in the nearest future. You will just have to save money, yes, and to treat people a little bit cheaper than you do today. What can we do about it?
Yeah, so I'm sure probably has a comment on that, but yes, this happens quite a bit when, especially when you're doing costing at a facility or a district level. Because exactly the kind of methodologies that works well for that are costing for reimbursement, and then you're doing it, like I said, per visit or per patient or per bed. And that's one of the reasons why we try to cost instead of, at that level, we try to cost it sort of per thing that happens. So per intervention rather than per person. But so yes, on a practical sense, what do you do when you have that sort of thing? When the budget is fixed and you have to do that? There's a difference between financial costs and economic costs too. So the first thing would be to say, to fit within the budget, you have to make it fit within a financial costing, while in reality, maybe the economic costs can be different. And that maybe by doing an economic costing of it, you can sort of figure out what the real, not how much you're spending per se, or how much you're getting budgeted back from it, but where the bottlenecks or where the constraints are going to be. If so what I would say is doing a costing because you have to do a costing in this kind of circumstance almost leads to maybe being worse off than you were before. Because if you didn't have a costing, you could sort of say, have some flexibility. But if you have to come up with a costing that way, you have to make it fit to the envelope you have. Its usefulness, maybe as I said, is to identify bits that really drive the costs, and that maybe aren't so clear or so evident. That maybe it isn't, the costs aren't going to be driven by human resources. That's the obvious thing, that the costs are always going to be driven by human resources, but maybe that's not the case. So, sort of, the worthwhile reason to do a costing in that sort of circumstance is to just sort of figure out what the economic cost behind what the actual budget is going to be leading to. But if you do the costing, you have to report it, and then that's going to have some outcome. So I don't know. It's probably one of those no win, loss kind of situations. So yeah.
So just on that, if I may, I mean, that's the classic problem that we address in cost effectiveness analysis, where we have a fixed budget and we want to achieve the greatest population health impact. So, I mean, naively, from that perspective, we would say, well, you need to prioritize and do the things that give you more value for money. That might mean stopping to do other things. I'd like to know what is the margin for action with this fixed budget? Is it fixed budget and as an additional constraint, we have to do everything that we did last year? Or is there margin to stop things, not, wind them down, shift resources toward more performing sectors? I mean, one of the most cost-effective things we can do in health is have effective tobacco taxes.
Yes.
Yeah. So, I mean, that's not very expensive. It has a reasonably good health impact. But where it does get complicated is in the implementation and the enforcement and so forth. I would certainly want to look at areas where we're perhaps underinvested that are very high, have very high value for money. A fixed budget problem, I've never heard it expressed, in such a clear way.
But
That's actually very interesting.
It's really in that way, in practice.
Yeah.
Yeah, so in that sense, I guess a costing study would be less useful than cost effectiveness study.
Yeah, please. Thank you.
Okay, any other comments? We need to remember that tomorrow, Anna, you're going to talk about sources of data for NCD investment cases. And then we'll be putting those two together, as Odd said, in the practical session that will allow hands-on experience with the OneHealth tool. Okay? So, yes, please.
Just I have to comment on this. It is good to know that there is a progress to disaggregate information on prevalence, the incidence by gender and by age. But is there a perspective to get this by diseases using the classification ICD-10 and to make the link by the system of health accounts 2011? Maybe it would be better. The second comment is related to information that we find in the different tool, the choice model or OneHealth tool, and the data what we find in the country when we are doing the study. Sometimes we have a huge difference in terms of the year of producing the data, and this is make a lot of confusion. And sometimes we have information from 2012, the other 2015. So how do you think to manage with this? Another comment is related to the risk, the relative risk of the risk factor, and to relate this to the diseases and the population in need for more accurate. And the second one is related to the intervention program. Sometimes they are managed by a different level. There is a department for that country, but also there is a health facility who manage, and they have their specific finding and so on. They complicate the situation. Thank you.
Yeah, so lots of good comments. I'll start with the last one and then maybe go backwards. So first, yes, you have to have an assumption that you can make or help make decisions at the different levels, and that if there are data at the subnational level that's better than at the central level, it is possible within the tool to do subnational assessments, not just within a specific program, but within a specific region or within a specific area, and then aggregate them together. It's a bit difficult if you only have one subnational area that has data and the rest don't, then you get up with a sort of strange aggregate number together. But the idea, and linked to the second question, is it's always good to use the newest data there is, or the most reliable data there is. So if there's a particular doubt or risk that the country data is a bit newer but maybe not as reliable, then it's a sort of discretionary decision what to use. The general guideline is if it's newer, it's better to use that. But there is no problem, say, in using country data from 2015 and default data from 2012 because it's treated as whatever the latest year is. Anyway, it's always treated at current. It doesn't really matter maybe if something is from 20 years before, the tool always treats it at whatever this year is. And then you're looking at whatever the latest number is versus what is going to happen in the future. There's always the risk. The data isn't relevant to reality, and so then we're always playing with modeling things that are based off of a picture that isn't close to reality, but we have to sort of accept that we have to use what best data we have and sort of play this in a caveat that numbers may be inaccurate things to what the data is. The third question on the risk factors, and I guess the first one on the global burden of this, the classifications. Yes, at the moment, the way this tool is structured is as it is, and we want to improve it, and this area is maybe one of the newest parts of the tool that we have, and that is working. So ideas like this are always positive to include. The only thing to remember is that I didn't put it on. There was the one column that had all the different sections. There's surgery. I didn't put the list of what's coming next. There's a bigger list of modules that are waiting to be added to the tool than are already in the tool. So, and this always depends on the programmers themselves that have to add these too. So we want to keep making improvements. We want to, maybe the NCD, since it's still not really finished, is one of those things that we can continue making changes. So the idea is this is always a tool that's continuously being improved, and that ideas like this are always a positive thing to take on and to think about how to change, make it better.
What I would present would conceptually slot into the area of calculating economic burden, which is to say, labor market impacts of changes in health. But it's not something that would be an implementable, operationalizable part of anybody's workflow at this point. So I can talk about those ideas, but my sense is that we need more, nitty-gritty and maybe less ideas at this point. So I'm actually thinking, I want to solicit James' attention on this question as well. What can we say about what we were billing on the program as the WHO economic burden tool? What is it? How does it work? Can any of the analysts who've used that say how they've worked with that, what it's like? Or, that's what I would be addressing, but with something that is still very much under development and therefore not ready to be plugged in to the workflow. So, to the economists in the room, it could be interesting, what I have to say, but I just want to ask the question out loud. Do we want to maybe take a step back and handle that in a different way?
Sure. I think that sounds good, and I think it's very important that we try and make as much of this time very specific and practical orientated, bearing in mind that I hope that for a number of people the next step will be out in the field doing some of this work, maybe with somebody who's had experience of it before, such as Anna or others. But I think we need to be trying to make sure that this is very practical rather than theoretical discussions. So, let me ask James if he wants to make some comments on that, and then Anna as well. James, you have undertaken a desk-based investment study in Vietnam, is that right?
Yeah.
And Anna, you have just reminded us undertaken three. Do you want to just remind us which ones those are again, with your speakerphone on? Not speakerphone.
Yes. I participated in 3, Kyrgyzstan, Belarus and Turkey.
Okay, fine. Let's just remind ourselves. Jill, you've been involved in which ones?
All of those.
All of those. Alexei?
Yeah, I've been personally involved in Kyrgyzstan and Jamaica.
Okay, all right.
And partly in Vietnam one, but in terms of coordinating things.
Okay, fine. So James.
Yeah. So assume you've used the economic burden model for all three of those investment cases, is that right? In Kyrgyzstan, Turkey and Belarus, yeah.
Yes, in all three.
And I used the same economic burden model for Vietnam, and it was used on the first occasion for the first investment case in Barbados. And it was developed by, I can't remember the name of a lady who was doing an internship at the WHO, but that was when the model was made. And so I found that it was more of a template than an actual model. We have, like the OneHealth tool is super sophisticated, and the NCD costing tool that we were just talking about up there is a model that is Excel based, it doesn't have its own interface, but is also very sophisticated. But this Excel based model we're using is, I found it's more of a template. I was able to make various modifications to it, and I'd also be interested if Anna had made any modifications too. But I wouldn't say it's set in stone how you conduct the burden analysis at the moment. Certainly doing impacts and the costing analysis, there are set ways of doing this, but the burden seems a bit more flexible at the moment. It's not a set way of doing it. We know that we're calculating the costs of absenteeism, presenteeism, and premature mortality. That's sort of our baseline, and the way we go about doing it is, it's not concrete.
So if I might jump in, it's not calculating the direct costs of treatment. It's not calculating the health system costs. It's calculating the imputed losses in the labor market in terms of productivity and wages. And so economic burden is a fair enough name for that, but I think I see exactly what I see exactly what you're talking about there. And then so that tool is really just taking evidence from the literature about how much certain conditions result in increased absenteeism, presenteeism, early retirement, and disability, and then using average wage rates to calculate some imputed loss.
Yeah.
That's essentially what we're talking about.
Yeah.
So would you call that a friction cost or a human capital approach?
Well, it's quite easy. It's quite easy to apply both methods with the model, because essentially you use the same data and you use a different sort of group of, say, one or two statistics for the human capital method, and then you just use a different set of statistics to your baseline model for the friction cost method. So there's actually another investment case that was done in Fiji. Can't remember the name of the person who did it, but she did both the friction cost method and the human capital method and was able to compare between them. But the issue that I had with Vietnam, I did the same thing, presented it to Vietnam, and they were amazed by how large the difference was between the estimates, and they thought, how can one be billions and one be hundreds? They were like, this doesn't give any sort of direction. So yeah, we ended up dropping the friction cost method on this occasion. Can't remember what your question was.
No, that's a good question.
Did you want to add to that?
Yes, I agree with James that economic burden model template is rather flexible, and it's good because with OneHealth tool you did something you do not understand what happens with the numbers, but in case of such a template you can adjust it to the exact circumstances and to exact data which are available, and then explain what you did and show the results. And yes, in all three cases we used the human capital approach for one very simple reason. It is more suitable for the advocacy purposes because of the big numbers.
Yes.
Yeah. Okay. Any other comments or questions? Back to you, Jeremy.
So again, I mean, my feeling is that I would be reluctant at this point to present 10 additional slides on economic theory that give us other ways of calculating, impact on output, economic outcomes like labor market outcomes and output. If anybody would volunteer to sort of stand up and show us a few screens of the burden tool, that might be useful.